Unit 7, Section 2. This is the key terms for Section 2. Our first term is ambulate. To ambulate means to walk or to assist our residents to walk. Our second term is atrophy. Atrophy is when a muscle decreases in size and strength, and that muscle becomes weaker. This can be from a lot of different reasons. This can be from lack of use. This can be from disease process. Our next term is body alignment. Body alignment is the correct position of the body for good posture. This provides for the best functioning of the body. So we discussed previously body mechanics for nursing assistants for using our bodies in the best way. Body positioning or body alignment is how we position our residents for the best comfort, pain management, preventing complications, and to help their body function the best way. Our next term is Fowler's position. You may sometimes hear it called high Fowler's position. This is when we position the resident's body with the head of the bed at least 60 to 90 degrees. So they are sitting upright at a right angle, similar to the way I am sitting right now. Our next term is to pivot. To pivot is to turn with your whole body, not twisting your back. When we assist our residents with transferring, we want to pivot our body rather than twist. This helps protect our back. So if you have a resident and you help them to stand up, rather than twist your body, you're going to move your whole body. You're going to move your feet and pivot so that you're keeping that load of weight in front of you and not twisting and putting pressure on your back. Our next term is semi-Fowler's position. So we said Fowler's position was when we position that resident with the head of the bed at 60 to 90 degrees. So semi-Fowler's position is when we have that resident with the head of the bed at 30 to 45 degrees. This may also be called low Fowler's position. We use this position when we have residents in bed, most often that have respiratory disorders where it's difficult for them to breathe laying down flat. So we want to keep the head of the bed up because when the head and the shoulders are above the chest cavity, it's easier to breathe. We also use this very often with residents with feeding tubes. What we're doing is keeping, again, the head and the shoulders above the torso level because we have gravity helps us then keep liquid in the stomach pouch with those folks that have feeding tubes. Our next term is side-lying position. This is laying someone on their side in correct positioning for good body alignment. You may also hear this referred to as lateral position. Lateral means to the side. Our next term is supine. Supine is when your resident is laying flat on their back. Unit 7, Section 2. Continuing the outline, we are going to discuss the effects of immobility. Immobility affects all of our body systems. We are going to break it down by body system. So our first body system is our circulatory system. This is our blood, our vessels, our heart. So when people are immobile, they are at higher risk for blood pooling in their tissues. They are at higher risk for blood clots because the blood is not moving through the arteries the way it should be. As we are active and move around, we help our heart and our body to move our blood through our system. So people that are immobile don't have that benefit. Poor blood flow can cause swelling or edema in the tissues. This can make the workload of the heart harder. And also, all of the body systems are able to function less when they receive less blood flow. Our next body system is the respiratory system. Immobility affects the respiratory system in that our lungs are not able to expand as fully as they would if a person was mobile. This puts that person at higher risk for respiratory infections or respiratory disease. When we are mobile, when we stand up, when we sit upright, our chest expands, our lungs are able to expand, and it makes breathing easier and more effective. For people who are immobile, those things do not happen. Our next body system is the urinary system. When we are immobile, it is often difficult to completely empty the bladder. Your bladder is suspended by ligaments and tendons in your pelvic cavity. So for people who are immobile, people that sit all the time or lay down, that bladder can start to hang at an angle because the pelvic floor muscles become weak and those tendons and ligaments start to not support it as well. When your bladder is not positioned correctly, it's difficult to completely empty. This puts people at higher risk for urinary tract infections. This also puts people at higher risk for urinary stones to develop. Our next body system is the digestive system. When we are immobile, there can be changes to the digestive system. We can have a lower appetite. When we are mobile and active and moving around, we are stimulating our GI tract, our gut, to move. That is called peristalsis. So when we are immobile, when we just sit, we don't have that activity level. We're not stimulating our appetite. We're not stimulating our body to move the food along. Inactivity can cause indigestion because your food sits in your stomach pouch longer. It doesn't move along through your digestive tract, which can cause some indigestion. This also can lead to constipation because when we are active and mobile and moving around, when we're stimulating that GI tract to move food through our intestinal system, we have regular bowel movements. When that doesn't happen, when our GI tract is slow and sluggish because of immobility, that puts you at higher risk for constipation. Our next body system is the musculoskeletal system, so our muscles and our bones. When we are immobile, our muscles become weak from lack of use. They can atrophy, they can decrease in size and strength, they can become less flexible, they become tight and short, and this can lead to contractures, which is a very bad complication of immobility. Also, being immobile puts you at higher risk for osteoporosis. Not bearing weight on your bones encourages them to become weak. The bones can become porous, which puts residents at higher risk for an injury or fracture should they have a fall. The last section on immobility complications is how it affects us psychosocially. How does it affect residents mentally and emotionally? When people are immobile, it can affect their self-esteem, their dignity. They can have low body image. They can have poor self-concept. They have increased dependence on others. They often have inactivity. They become withdrawn and isolated. This can lead to depression or loneliness. This can complicate mental health issues. So maintaining our residents' mobility is very important. Our next section discusses body alignment. So we had the key term body alignment. We said this is the correct positioning of the resident's body, how we position them for good posture, whether they are sitting or lying. So when a resident is sitting in a bed, we want them to be sitting with their hips to the back of the chair so that they are sitting straight up, Head and shoulders are evenly over the torso. Their hips are at a 90-degree angle. The knees are at a 90-degree angle. And the ankles are at a 90-degree angle. Feet are flat on the floor. If you have a resident that's in a wheelchair, a lot of our residents like to propel themselves with their feet. So we want to make sure that their feet can be flat on the floor when they are sitting. We also need to make sure that we do have foot pedals for residents for their wheelchairs. In the event that we are going to push them any distance, their feet can be up off of the floor to prevent any injury. When the resident is sitting in bed, we want that resident to be that their hips are where the bed bends. So when we raise the head of the bed, not just their head moves, but their whole upper torso moves. So when we have that resident in bed, make sure that they are sitting where the bed bends. You can use pillows or positioning devices to achieve that. When a resident is lying in bed, we have a few different positions. Supine position, we discussed, is when a resident is laying on their back. We want a small pillow under their head, and we would like them to be laying flat. The reason we want them to be laying flat is because when people sit, especially residents that sit in wheelchairs, the knees and the hips are bent for long portions of the day. So we want them to be laying flat so that those can stretch out back to flat position. When a resident is lying on their side in bed, this is called side lying or lateral position. We want to use pillows or positioning devices so that that person stays on their side and is comfortable. We use just the head pillow when they're on their side so that it's not anywhere near their face. We want to make sure they have a pillow behind the back for support. We want to support, when they're on their side, the front arm with a pillow. And then we want one pillow between the legs to keep the knees from rubbing and the ankles from rubbing. This also helps keep them in that side lying position. The last of the laying down positions is prone position. This is when a resident is lying on their abdomen. We do not use prone position very often, but there may be times when it is required. We only do this if it is directed by a nurse or we have a physician's order to do so. Make sure we're turning that resident's head to the side so that they can breathe adequately. Make sure that their feet are positioned where there is a space between the end of the mattress and the footboard so that their feet are not being cramped. We also want to always make sure that their arms are near their head so that for correct positioning and circulation of the arms. And then whenever a resident is laying in the bed, but especially with prone position, we want to make sure that they have a call light for safety. Anytime you have a resident laying in bed, you want to use the appropriate pillows or positioning devices that are ordered for them, and you want to make sure that they're comfortable and that they have a call light within reach.